the key points that we're going to look at today is just the whole progression of atherosclerosis, which I find absolutely fascinating. When I always, thought that actually your atherosclerosis, or like a heart attack, was just caused by a plaque clot that got went down an artery, and then I found out actually none of that's true. And so we're just going to look at comparing myocardial ischemia with myocardial infarction, and how the progression is related. We're going to look at thrombus formation and the wave front phenomenon. All of these things are really helpful for me, just understanding what's going on. And so when someone's having a myocardial infarction, looking at exactly what is going on and how it is very time dependent. The old adage that time is muscle becomes very apparent here. We're going to have a look at some of the typical and atypical cardiac symptoms. And as you probably know, typical cardiac symptoms are based on middle-aged white men. So anybody else having an MI could, is likely to have what we call atypical symptoms. Lead placement in acquiring a 12-lead ECG. If we get a chance, we'll go over that. But pretty much that's something that hopefully you will all have had a go at, or at least be able to start practicing now. If you're Wellington based, you don't need to do V4R or the posterior leads because our core pulses now do them, but it's still a good practice to get into. And then just why we would do a V4R or posterior leads. So I guess the key definitions here are there are three areas that come under acute coronary syndrome. The first definition is angina, and it's actually a reversible myocardial hypoxia. It is not part of ACS. So if somebody has angina, they are not considered to be part of the ACS umbrella. The key point that I want to get across here is it is not our job to diagnose angina. So if somebody has chest pain and they recover completely post-GTN, that doesn't mean that they have angina. That means they're still going to hospital. If they're diagnosed with angina, that's a different scenario, but we do not diagnose people with angina. Cardiac chest pain, ED. Unstable angina is a progression of angina. And so patients would have had a history of angina, but then what starts happening, instead of pain on exertion or undue stress, the pain can come at any time and more frequently and at rest. And so that is kind of the beginning of our ACS diagnosis. Then we have a acute myocardial infarction, and we're going to go into that further of what that is and what that looks like. And that can be a STEMI or a non-STEMI. So STEMI is obviously a lot easier for us to diagnose. And then acute coronary syndrome is the term that describes all of these things. So the ischemia, the infarction, and the unstable angina. So any questions about any of those terms? Okay, so myocardial ischemia has a number of mechanisms that cause it. The most common one, and the one that we get called to, is a blockage due to a thrombus. And so that's when we're looking at myocardial infarction. We can have global ischemia due to hypoperfusion or hypoxia. So either there's not enough oxygen for the blood to carry, or there's not enough blood for the to carry the oxygen. Cardiac procedures can also cause myocardial ischemia. and then coronary artery dissection or coronary artery spasm. So you probably heard the term Prinz's metal angina, and also secondary to recreational drug use, and specifically cocaine use can cause myocardial ischemia. And people who die very young of sudden cardiac arrest often do have a history of drug use, and so that can actually cause ischemia and then cardiac arrest down the track. So this is a cool little topic, and this is the progression of the atherosclerosis, and we'll see how many times I can continue to say that today. And so this is basically the pathogenic process that someone goes from a healthy heart and arteries through to a myocardial infarction and possibly death, cardiac arrest. So it starts with on the lining. So I'm just going to show on the endothelial lining of the heart here. There is a site, and it's either like a denudation or increased permeability. And so almost like a graze really is where then monocytes can actually travel through this area in the endothelial and start causing damage. So it can just start with this small little abrasion, and myocytes being white blood cells. So the next stage is the lipids. So lipids seem to love this kind of injury, and they hang out around it. They're not there all the time, they come and go, but there's often you'll find these fatty streaks around any injury in the arteries. And then we have monocytes, and these take form from the macrophages, and they digest the lipids. So the monocytes right at the beginning, they actually start eating up lipids that get through this endothelial lining, and they form what are called foam cells by digesting these lipids. And as you can see, this artery now is getting narrower and narrower, and in behind the endothelial wall, we've got these foam cells building.
Amanda, just a quick question. So what sort of things are going to cause the initial insult to the endothelial lining? Like, is there anything particular that causes the damage, or?
Yes, there is, and we're going to have a look at that a bit later. And really it's in two distinct categories. There's choices, lifestyle choices, and history. So, you know, our parents and that sort of thing. So we will look at this earlier. So high blood pressure, you know, that tension of the blood pushing through the arteries at pressure all of the time is one of the things that can cause this damage of the lining. So these are foam cells, and I think it's a great little picture there. And then what happens is these foam cells start forming caps, a fibrous cap. So instead of being kind of soft and pliable, they become more plaque forms on them, and they become less pliable. So at this point here, the patient probably has no idea that there's anything going on. They haven't suffered any chest pain. There's been no shortness of breath, no symptoms, but they have arteries that are starting to look like this. Okay, and then the next thing that happens is the deposition of platelets and fibrin on the surface. So these platelets start to adhere on the surface of the endothelial lining, And this sort of progression here can take 10 to 15 years. So it happens over a long period of time. So eventually what will happen is these caps will either start to degranulate or ulcerate. So they'll start getting infected and breaking down. And then we have this next stage where actually thrombus is starting to form, and we can see here there's a hemorrhage that starts to form in behind the endothelial lining. And without anything to stop the hemorrhage, it is just going to keep getting larger. And so the next stage is that can actually rupture. And when that ruptures, the body then sends thrombus to try and block this bleeding and reduce the blood flow. And if that continues, I've moved my mouse around, then we end up with a complete blockage of thrombus, which is why we would give someone antithrombolytics. So this is just like a quick little picture of how this builds up. So initially it starts very slowly. It's a slow progression. In the end, it can happen quite quickly. And in the big picture, we can see that this is where can you see the mouse on that one?
Yeah.
Yep. So this is where the thrombus now has blocked off the artery completely, and there is no oxygenated blood getting into this section of the heart, which means that the cells and the muscle starts to die. So any questions about that progression? I know I've gone over it quite quickly. I'm trying to just break it down to, the pictorial plain language side of it. So, and all the notes are there. So the wave front phenomenon is a good way to understand what's actually happening when somebody has myocardial ischemia. That may lead on to myocardial infarction. And so the infarction is when there is that complete blockage. So you've got the endocardium, which is what we were looking at before, and the myocardium. And so this in this area here is where the foam cells and the myocytes and the monocytes start to form, and then they'll rupture through. And then you've got your pericardium on the outside here. So there's three areas that we're looking here. There's ischemia, there's injury, and there's necrosis. So ischemia is the early stage where oxygen is not getting to the tissues, not getting to the cells, and cell death starts to occur. And so from when ischemia starts, 20 to 40 minutes before we start having injury. And I'm playing on the wrong screen here. So that's 20 to 40 minutes, ischemia, so lack of oxygen, starts becoming injury. And after 30 minutes, you're looking at a beginning of necrosis, and that's the cell death. So that's not coming back. That's now dead tissue. After an hour, 30% of that wall of the heart is now in necrosis. So that's 30 minutes. And we're hoping at this point the patient is going to have symptoms. But it's not long before a third of the heart's wall is now necrotic. And after 2 hours, it's up to 50%. And this is why we say time is muscle. And if we do have someone who does have cardiac chest pain, it's something that we want to get on to very quickly. After 3 hours, 60% of the heart muscle is now necrotic. and 6 hours, 90%. So after 24 hours, there is death of the heart muscle. So this is a time-dependent diagnosis. So risk factors, and Julia, you were asking about this before. And so these are risk factors that we see. So there's modifiable ones, some things that our patients or ourselves can do something about: smoking, hyperlipidemia, diabetes, hypertension, chronic stress, and abdominal fat. That's something that we could modify. Then also part of this is family history, males more than females, although females are more likely to die from an MI, age and ethnicity. So unfortunately, once again, Māori and Pacifica are at the top of the list for coronary artery disease. And South Asian also have an increased risk of MI. Interestingly enough, the South Asian population tend not to have what we'd call our typical symptoms of an MI.
So are these all just genetical factors, and have they identified like a correlation, a genetical correlation, or?
So if you have a family history of coronary artery disease, stroke, then you are more likely to also suffer from these conditions. So that's where the genetics comes in, as your history and also your ethnicity. Don, I saw you. Are you getting all excited about illness scripts? I saw your face come up for a while.
No, actually, I ran through what I was going to say before I said it for once in my life, and it seems to have worked out quite well. So I'll just mute again.
Okay. Okay, so what we're going to do here is try and come up with a list of as many typical symptoms as we can. So we can either call them out, or you can type them out. And then we're going to have a look at some atypical symptoms. So what are some of the typical symptoms that we would see in someone who had called because they're going through either myocardial ischemia or myocardial infarction, or indeed unstable angina?
We're looking at sort of chest pain, aren't we? It's typically central radiating, and the type of pain, isn't it? Like a head.
So how would we describe it?
I think there's lots of different ways, but mostly I think typically it's sort of like heavy or crushing, or like something sitting on their chest, or and tends to be radiating.
Yeah. So Ray, where does the radiation typically occur?
Down their left arm or chin, around their face, down their neck can be.
Yep, the neck, the jaw.
Yeah.
Left-sided.
Left arm, really. That's our main one we get called to too. I've had a left arm. After work, I felt like I was just, my left arm didn't feel really well. I think that's because it's all advertised as that, if you feel pain down the left arm.
Yeah. And I've spent all day lifting crates.
Yeah. But we'll call you at 3 o'clock just to say that.
Yeah. So that's the pain, and sometimes that pain actually radiates to both shoulders and down both arms as well. So what other sorts of things might we be looking at with our typical symptoms of chest pain? So are any other associated symptoms?
Here
you go, Rowan.
Sudden short of breath too, so like they'll feel quite breathless.
Nausea.
Yeah, nausea and vomiting.
vomiting, urgent need to go for a bowel motion.
Oh,
Yeah.
yeah, we don't want that.
What's the old trick? Yeah, go, just leave the toilet door open.
Mm.
Diaphragm, like sweaty, pale, clammy.
Mm-hmm.
Impending doom.
Really?
Impending doom. Yeah, we don't like that one at all. So anything else that we might look at as symptomatic? So thinking of their past history.
Yeah.
What's one of the scariest ones that they say to us if they've had a history of ACS before?
This feels like my last heart attack.
Feels like my last heart attack, and I've
Yeah.
got. Feels like
Yeah.
the same pain I had when I had this.
Yeah. And what might they be feeling like other than pain? Are they going to feel anything else in their chest possibly?
It could be just a tightness.
Yep.
You know, struggling to catch your breath.
Mm.
Yep.
I
They want
think
to cough.
Yeah. Yep.
Coughing too.
What about if they're maybe a rate related pain that's causing the ischemia? They often feel the palpitations.
oh yeah.
And some of the other ones I've got here associated with this exertion.
So
Yeah.
it gets worse when they walk around, or
Yeah, it can do, or it came on when they were involved in heavy activity and stuff. They may have some edema associated with it, pulmonary pedal or ascites, and a clear one is syncope or near syncope, which I think Don's case was very much a near syncope. And sometimes that pain can be burning or indigestion-like pain as part of a typical symptom, which is really
That one.
one of those key ones where GTN can actually resolve an indigestion pain, but that doesn't mean that we can rule in that that's what it was. All right. So any abnormal signs that you've ever come across?
Burping.
Burping?
Yeah. More like a sharp pain, like they might say it's a sharp pain rather than a heavy or dull.
Mm-hmm.
You know, that it's not radiating.
Yep. So what sorts of places could the discomfort just be localized to in ACS?
Can be abdo.
Well, just
It's
Really around that.
yeah.
abdo and epigastric pain,
Yeah.
right? And who's most likely to get those?
Is it women?
Oh.
I go, Raven. Are they
Yeah.
more the epigastric?
Yeah.
They know why.
I'm sure there's a reason. I don't know why.
Does the
So
heart
the
lower or something?
referred, I think it's a referred type
Right.
pain, but I don't know why it's more common in women. So some of the atypical symptoms are localized discomfort either in the face or the jaw or the neck or arm or shoulder without the central crushing chest pain.
Yeah.
So it can be that localized pain. Also pain in the lower or upper back can be a symptom. Pain in the tongue or the mouth.
Yeah, I've heard of that one. I think I haven't heard
Have
of
you?
just lower back. That would be That would be freaky.
Yeah, yep. And so that's why if we start hearing these symptoms, all of a sudden we're not wanting to just go, this isn't,
It's
rule it out. Don, can you have a look at the chats for me?
Oh,
Breathlessness without pain.
Yeah.
So somebody's feeling very short of breath. In the first STEMI I ever went to, he just denied that there was anything wrong with his heart. He was tombstoning, and said he was just short of breath. And I said, well, I've listened to your lungs and they're all clear. There's only one other thing there. So anxiety, and that's a really big atypical symptom that we can rule out so quickly. Oh, you're just anxious.
Right.
And so that's really important. And we know that anxiety on its own can be an atypical sign of ACS.
And
Sudden
young people too, even though they say it's age related, but yeah, that they always rule it out like, oh, they're just anxious.
And if you go without doing a 12-lead ECG,
yeah,
you might as well just send your invitation to the HDC.
Yeah, I think we had like a guy who was 38 and he was having a STEMI, and he said his father died at 46. His brother had his first cabbage at 30s, and he had already had one, and he was like 38 or something. It was insane.
Yep. So remember when we were looking at the modifiable and unmodifiable causes, then family history is a really big one. Sudden fatigue, weakness, or malaise.
I read some research about that, and they were saying particularly in women, a third of women having an MI will present, and the most pressing of a range of symptoms is that they know that there's something wrong. It's that sort of I don't feel right, and it's worrying sort of feeling, as opposed to it'll be all right. Yeah.
Yep. That's how someone very close to me described their stroke.
Yeah.
And it's just, I just don't feel right. And the only reason we picked it up is because they were talking, dropped their heads into their hands, said, I don't feel right, looked at me, and their left eye was barely visible.
Wow.
And then it came back after about 5 minutes to completely normal. But they'd had a stroke in the meantime. So lightheaded, dizzy, and not with it can be some of the other atypical symptoms. So you can see there's quite a symptom list. And, I think really important when we get into illness scripts and that sort of thing, understanding that there's so much we can rule out and, I think we can rule out where we do need to be doing a full assessment and be pretty sure. So anything we've missed there?
Is it worth talking about, or you're going to do this a bit later about the non-STEMIs, or are you doing that?
So a STEMI and a non-STEMI, the only difference in presentation that you might get is what turns up on your ECG.
But they've got signs.
Yeah, so you're no less or more likely to have extreme pain with a STEMI or a non-STEMI. Being associated with exertion is not actually, these symptoms are not going to change depending on whether it's a STEMI or a non-STEMI. It's just that a STEMI rules in that it is a STEMI. It doesn't rule out that it's not a non-STEMI. I think that made sense.
Sitting there going.
The great thing about a STEMI is it has been ruled in as long as we're reading it correctly. But that does not exclude a non-STEMI at all. So non-STEMIs are more scarier. So if we are trying to rule in a myocardial infarction, some really strong clinical features is that it's described as a pressure, it's worse than previous angina or similar to, or the same as a previous MI. We talked about that before. Associated with nausea and vomiting, associated with diaphoresis, and associated with exertion, which can also be a symptom of exclusion. So we just need to be really careful with that. It can be described as burning or like indigestion, radiation to both arms or shoulders, and radiating to the right arm. So it's really, really important that if there is any concern whatsoever and anxiety, we know as a symptom, that we do gain a thorough history and then use our rule in, rule out differential diagnoses to work really hard about how we're going to treat this patient. So some of the symptoms associated with non-cardiac, associated with exertion. So we want to be really, really careful not to rule out ACS just because exertion has been involved. And so what we're looking at here is it exertion that's caused the ischemia, or has exertion caused something localized? And so that's, again, we just, just because the patient, the pain is associated with exertion, we need to get that thorough history. So if it's in an inflammatory location, so somewhere where they could have strained or pulled something, is it reproducible by palpation? Is it described as sharp? Is it positional? Or is it described as pleuritic? So again, to rule out these things, it's a thorough history. We're going to want to do an absolute complete secondary survey and rule things in and out. So any questions around?
Probably. Can't think of it.
No, that's okay. If you were going to do a illness script for acute coronary syndrome, I think that the symptoms are so broad but you can't really just go, well, these are the key symptoms, because it depends on who you're going to. And within 20 to 30 minutes of us dithering around trying to decide, already muscle is starting to become ischemic. So lead placement, what I made my students do in class, and unfortunately they're not going to have time for that tomorrow when we do have the classes, they actually got to draw their own chest and put little dots on. But I suggest just for practicing that you get people that to help with that. So what have you guys been taught about breast tissue and 12 lead placement?
I don't know about taught, but basically with the paramedics I've worked with is to go underneath, like if there's a bra there, to go underneath the breast tissue.
I've been taught to go over the top.
No.
Like just over the top of it depends where the line is. Like if the boob is hanging down to their belly button, of course there's no flipping it over there. Well, a lot of our patients are like that, and you have to, I don't know. I've been told to go over the top just as long as it's still in the line. So, but
and there's a lot of confusion around that 4 lead placement, whether we go over or under. I think the best thing we can do is expose. So if there is a bra, remove it.
Yeah.
In ED, they always remove.
You suggest lifting it up and going under. I just.
If I was going to do that,
I think boobs are boobs, but
yeah,
it's like for them, I feel more aroha for them, you know.
Yeah. If I do have to do it, I always let them know, and I'll try and lift with the back of my hand, not grab. Just slide the back of your hand under.
Yeah.
Any thoughts on that, Don? And because I'm aware that you do third year cardiology, lead placement and breast tissue.
Yeah, so the general rule is over.
Okay.
And the reason they say that is that when people attempt to go under, the chances of incorrect placement are significantly higher. So that's why the over. And also, if you're a guy, it doesn't matter whether you're palm up or palm down, it just doesn't feel. just never feels quite right. I always feel my mother's looking over my shoulder.
Yeah.
Making a bit of a tisk sound.
Yeah.
And also, I think the ECG manufacturers actually recommend over.
Yeah.
The Life Pack definitely says over.
Okay. Yeah. So just following the line as close as you can.
As close as you can. But if you're having to lift, yeah, because I think what happens is particularly V4 always tends up too low if you try and go underneath.
Yeah. And it's sweaty under there, you know, so that's why I don't like.
You find things you didn't really want to find.
That's right. Well,
TV remote.
What they had for dinner, so.
This is being recorded.
But it's not sticky, you know, it will keep falling off. That's what I'm, you know, saying.
Yeah. So yeah, I guess the key point is if you can remove the bra, and I always like to, if they're not already in the ambulance when I'm at ED, just grab a couple of gowns, because that can make things a whole lot easier, particularly if somebody's wearing a dress with a petticoat and a pair of stockings and boots and a jacket. You know you're going to need to do a 12-lead ECG. So yeah, get the ambulance warm and I just keep a couple of gowns in there in case we need to, because as soon as they get into ED, you know they're going to get them into a gown anyway. So we might as well do the best by the patient and get the best data we can. Okay, so our first picture of the structure is for gaining the 12-lead from the front, and then at the back, this is where we would look to place V7, 8 and 9. So that's our picture, and so whenever I was practicing, I always just practiced on myself, and so V1, fourth intercostal space, 2, 3, 4, left of the sternum. V2 is opposite that on the other side. Fourth intercostal space to the right of the sternum. Oh, it's on the patient, not me, sorry. Okay, just having a blonde moment there. And then V3 directly between the leads, V2 and V4. V4, fifth intercostal space, mid-clavicular line. So if you should find that V4 does sit directly on the nipple, it's just something I'm going to have to let your patient know that that's where it's going to go. That's okay. V5, sorry, at the level of V4, left anterior axillary line, and then V6, directly, same line, directly under the midpoint of the armpit. Alrighty, so case study time. So you will need your CPGs out.
I try to use my phone ones. I hate using these, but anyway.
Okay, so Marjorie's a 52-year-old female who had sudden onset of 9 out of 10 sharp chest pain, came on while at rest. So what clarifying questions could we ask Marjorie?
So she's saying it's sharp, so we know the quality of the pain, we know it's 9 out of 10, we know the severity of pain, we know the onset while at rest. We need to know if it's radiating or not.
Mm-hmm.
What was she doing prior?
Yeah,
Mm-hmm.
to that.
Yeah.
So what was she doing? Like, as in, has she been out exerting herself with her chainsaw for 3 hours prior to this, or, you know, has she been watching Netflix all morning?
Yeah. Scrolling Facebook, commenting.
Well, that's high stress.
Yeah, it's high stress.
That's going to cause a heart attack.
Facebook as well. You need to clarify.
Okay, what else do we want to know from? So, did we get all the way through our OPQRST?
The onset.
So we need to know when, how long ago?
Yeah, how long ago? How long has it been going on for?
So 30 minutes.
And she still has it now?
Continued, yet still 9 out of 10.
Has she had this before?
No, she's never had anything like this before.
Okay. So maybe looking around other symptoms, signs and symptoms, like, you know, the shortness of breath or nausea, all those sorts of things.
She just said she's, when it came on, she all of a sudden felt quite fatigued.
Okay.
And the sharp pain, where is it? So where is it?
She said it's kind of in the central, but it's more to the left, and it's going back into her left shoulder. So it's almost going straight through her.
Okay. So I forgot what you just said.
So the pain is central, but more to the left and going straight back through to her shoulder.
She had this before, and the only other signs and symptoms is she's got lethargy. She hasn't got any other nausea, shortness of breath.
Oh, she feels a bit nauseated, and not short of breath. It's not hard to breathe, but she does feel like she can't quite catch her breath.
Is she pale or diaphoretic? Or
So she looks pale to you, not cyanosed,
okay.
and not diaphoretic, but a little bit clammy. So a little bit cool and clammy, more than what you'd expect her just to be sitting, you know, when she's sitting in her warm living room.
Sorry, Amanda, just to go back to the history, was there anything that made this worse?
No, it started suddenly about half an hour ago, and it has been getting worse since. But there's nothing that makes it worse. She's pretty much just been.
Coughs or takes a big breath.
No, that doesn't change it. And when she coughs, no change there. It's pretty constant. Yeah, just sitting there.
And is there anything that's made it feel better at all?
Well, you guys arriving certainly helped, but no, it hasn't really helped the pain. I just feel a little bit less anxious now.
Okay.
Has she any trauma? Oh, sorry, any trauma? Any falls recently?
No falls. She's pretty fit and active normally, and yeah, just does everything. 50 now, everything hurts, so does everything pretty solidly and doesn't do silly things, so no trauma.
Has she taken anything for the pain or?
So they mentioned on the phone when she called up about aspirin, but she doesn't have any in the house, only ibuprofen, which they said not to take.
Has she got any other medical history at all?
No, she doesn't at all. She fractured her arm when she was a kid, but no medical history.
So I'm assuming no medication she takes regularly?
Only loratadine for her hay fever.
Okay. Then obviously I suppose it's just pertinent to see if there's any family history of cardiac issues in her heart and her family?
Yeah, so her grandfather died at 60 of a sudden cardiac arrest, and he had 3 MIs prior to that. And her uncle died at 45 of a sudden cardiac arrest.
She's 52.
Okay. So I suppose now would be a pertinent time to ask for allergies. Any allergies to anything?
Not that she knows of, no.
But she's on loratadine.
For hay fever.
Okay. Sorry.
She's allergic to grass and trees and sudden temperature changes.
Like most of us now.
Yeah.
And I suppose it's just pertinent to ask because she's felt well the last few days, like she hasn't felt, she's been quite well up to this point. She hasn't had cough, colds or anything like that previously to this onset.
No, she's been well, and actually, to be honest, she when this came on, she got a little bit scared because of the COVID and stuff, and so she's just done a rat test, and that came back negative.
Lovely.
Because she heard about that cardiac thing with the COVID, so
yeah.
Okay.
Sweet. Are we happy to get some vitals?
I was just gonna.
No other clarifying questions? I mean, we might come out with the vitals anyway, so let's go for it.
Okay. So what's her blood pressure?
Good question. Let me get out my... I've got the wrong folder. Okay, I'm going to make up a blood pressure. Her blood pressure is 115 over 75.
Okay, and your heart rate?
Heart rate is 60.
Regular or?
It's regular, and radial strong.
Her capillary refill time peripherally?
3 seconds.
Okay, so we like
we just went tonk.
Okay.
So any other vitals you want? Think about rolling in, rolling out now.
Yeah, so just a respirate and colour.
Yeah, so she's, as we said, she's pale, slightly clammy.
Yeah.
And her respirate is 22.
22, okay.
Has she got a temp? Temperature, sorry?
Is 37.1.
Yeah.
Okay. And just, can we have a blood sugar?
She says no, she's not diabetic, and she's GCS 15, so you don't need one.
Okay, sweet. Awesome. Okay. So we'd probably be pertinent to maybe just have a quick listen to her chest.
And vesicular.
Vesicular.
Fields, yeah.
So heading towards more quite cardiac, do you reckon, Raywin?
Yeah, definitely with that that history. She's pale and diaphoretic. Her CRT is 3 seconds. Even though her blood pressure seems within normal range and her heart rate, there's still something going on. We'll get an ECG, eh?
Yeah. Okay. Nice work.
An aspirin quickly.
So we'll do the ECG, which just shows sinus rhythm.
Okay.
So nothing showing at the moment.
Okay. Awesome. And is her pain, are we allowed to give her the aspirin?
Get your CPGs out, Julia.
Oh,
yeah. We'll just position her first, Dave. First positioning, feet up, lying down on the couch if she is on the couch. We found her sitting on the couch, is that right?
yeah. So myocardial ischemia.
Going down.
So
This is what they number, okay? I normally run by the book, but the book's in the room. I'm old school too. So it's like-
number 12 lead.
It says the aspirin, yeah.
Yep, there's a 300 milligrams aspirin per os.
But you just said it come up with what? So regular sinus rhythm.
Yeah.
Okay.
Yep. So we're looking at the myocardial ischemia guideline, not infarction.
Yeah.
So it says do a V for R if suspected inferior STEMI and a posterior if we expect posterior STEMI, but we haven't got any changes on our ECG because it's coming up normal sinus rhythm.
So Julia, are you in the ischemia?
Yeah, myocardial ischemia.
Yeah. Mine is, it says that. It's like, do that.
Yeah. Okay.
So then at question mark, STEMI, yes. Go to the STEMI one, STEMI, no. So we're saying no.
Mm-hmm.
And we're going to try 0.4 milligrams of GTN, just checking the cautions.
Point what did you say? 0.4?
0.4 milligrams GTN. Sublingual.
0.4.
Is that on yours?
Yeah. Oh, GTN, yeah. Oh my God.
I say
I'm
How
sorry.
do you give 0.3?
No.
It's good.
I would say GNT, not G.
G&T.
Yeah,
So shall we?
I
Okay, so we're
think
gonna start with the aspirin, and
Yep.
she has her 0.4, and she has a systolic drop of 5, so down to 125, but her pain is reduced to now a 6 out of 10. She's got a headache though.
10.
Oh,
So
so
did we explain to her what was going to happen?
the side effect of GTN.
So okay, so what are we thinking about transport?
Definitely transport.
Definitely transport, I agree.
Yeah.
Cool. All righty.
And they're saying,
The 6 out of 10 pain.
yeah, depending on how she progresses, that we want to get IV access if significant pain,
Mm.
a dysrhythmia or poor perfusion. So after we've given that GTN and we're lying her flat nicely, what are her pain's gone down. What about her CRT? And we got a blood pressure. Any improvement in her capillary refill time or?
No, not at this stage.
Okay.
So the pain's come down, and you guys are transporting to the hospital. And I guess the only question is, are you going to get back up en route for analgesia, which is, unless it's significant, and it is actually
How far away from the hospital are we to?
10 minutes.
Oh,
Yeah. So by the time we get back up, we would have been near.
yeah.
Yeah.
So just 40.
Nice work. Okay.